Some patients will have severe low backache for many months, years together, and they won't be able to walk for say 20 minutes. They won't be able to stand and work for 10 to 20 minutes. Most of these patients would have consulted, but a few patients, rarely, maybe 1 in 500, 1 in 1000, come with mid back pain. So these patients have to be given special preference because knee pain and old age above 50-55 years. Youngsters having knee pain is an entirely different scenario. Most people are afraid of joint replacement and infection. Sometimes I've seen patients complain that I'm Dr. Nalanda, consultant trauma, spine and joint replacement surgeon in KG Hospital. So I've been working here for the past 3 years. Today I would like to discuss in brief about common spine conditions. Most people come with complaints of low back pain or neck pain, mudu vali illana kalthu vali. So these cases make up around 40 to 50% of daily OPD. In that, most common is low backache. The mudu vali, idu vandu any age group, all age groups are susceptible. Anyone can develop low backache. It varies in intensity, like dull aching to very severe pain radiating. Some patients will have severe low backache for many months, years together, and they won't be able to walk for say 20 minutes. They won't be able to stand and work for 10 to 20 minutes. They develop back pain and they will have severe pain in the thighs and calf muscle. Most of these patients would have consulted elsewhere and would have been treated with basic painkillers and physiotherapy. There will be some relief, but a few of the cases settle and remaining they still persist to have symptoms. So all these patients would be benefited with further examination and investigations in the sense X-ray and MRI. So, MRI, there will be many diseases like diffuse disc bulge, spondylosis, or it can be spondylolisthesis, or it can be primary canal stenosis. These cases can be managed surgically, doing a decompression or a discectomy, or putting screws and stabilizing the spine, or you can even fuse it. Some cases it can be infection also. Diagnose infection, MRI definitely helps along with other basic investigations like blood, X-rays. Few notable cases are the mid backache patients. Neck pain and low backache pain are very common, but a few patients, rarely, maybe 1 in 500, 1 in 1000, come with mid back pain. So these patients have to be given special preference because mid back pain is not that common. And once we confirm that the patient is definitely having mid back ache, like it's not a psychogenic pain or anything related to trauma, it definitely needs further evaluation at the outset. There's no point in waiting. So usually it will be a case of tumor or infection. So that much rare mid back pain is. If a patient comes with a mid back pain, it has to be evaluated instantaneously. So coming to cervical spine, being the most mobile part of the spine, degenerative disc disease is extremely common, and patients tend to have neck pain relating to the shoulder and upper limb. Sometimes patient might have radiating pain to both the shoulders, both upper limbs. In severe cases, patient might be unable to stand or walk. Their gait will be altered. The hand grip, hand strength will be reduced. They won't be able to do basic activities, mixing food or buttoning or unbuttoning the shirts. So such patients will have severe canal stenosis. Acute cervical disc problem, they will have severe radiating pain. At times, they even come to the emergency with unbearable pain, especially if it is on the left side. I'm not surprised if they are evaluated for cardiac pain, and once all cardiology tests are negative, then they hand over it to orthopedics, and we get an MRI and we see a huge disc. That much severe cervical disc disease can be. So those patients do a discectomy, and patient will be so happy right from the next minute they come out of anesthesia. They will be entirely relieved of the pain. It works like magic, a cervical discectomy in a acute disc prolapse patient. So now we shall talk something about knee pain and old age above 50-55 years. Youngsters having knee pain is an entirely different scenario, and what we come across most commonly is uh, middle-aged patients, old age, and having severe pain in the knees, both the knees, unable to stand and work, unable to walk, and the way they walk will be changed, the speed is changed, the tempo will be changed. So these patients most probably will have a very common condition, that is osteoarthritis of the knee. So most people are afraid of joint replacement and infection. Sometimes I've seen patients complain that we have seen our neighbors who have been not allowed to walk for 2 months, 3 months, and then the knee becomes straight. They won't be able to bend the knee. Even with the help of physio, they are still unable to bend the knee and walk. So infection does happen in any hands. Maybe one in 1,000 cases infection do happen. This is the same to any other surgery also, not only specific to joint replacements. So need not be very afraid of infections. And here, after surgery, we mobilize the patients from day one, day two, based on the pain tolerance. We expect them to bend the knee up to 90 degrees and keep the knee straight. They need not be bedridden, they need not be nursed on the bed for days or weeks together. We have a very good physiotherapy team here, led by Dr. Mohan Gandhi. There we have protocols for all patients with post TCAR. They do a very good job, and Dr. Sendil, our anesthetist, is excellent in pain management, post-op pain management. He gives various injections, blocks, and continuous infusions and all. Patients are extremely happy without any pain at all, to the extent that we don't give painkillers for the first 36 to 48 hours. And by the time day 3 of post-operative period comes, the major pain would have subsided, and then we control pain with basic medications. Physiotherapy will be intensive, and because there is very good pain relief, patients do cooperate very well, and we send them home walking. They will be asked to come back after 2 weeks for suture removal, and then once a month. Thank you.